Now, this is a very interesting X-ray comparison where we can see there are two X-rays. Both the X-rays are in PA view. So, in this first X-ray, we have a very beautiful comparison that in this X-ray, this is the left side, this is the right side, and we see this is the costal angle, this is overall a diaphragm, this is the area of diaphragm, this is the area of diaphragm. So, there is bilateral effusion, means these both costophrenic angles are almost blocked. So here is all angle is blocked, means effusion is for sure. Angle is blocked. So in this X-ray, this angle looks bit clear. So there is no left pleural effusion. But in here, there is haziness in this. So there is a minimal effusion in the left pleural area, whereas on the right there is pretty good pleural effusion. So whenever there is effusion, the DDs which comes into the mind is either the patient will have LRTI or pneumonia. So infective etiology will cause effusion, or congestive heart failure will cause effusion, or fluid overload will cause effusion, or renal failure, nephrotic syndrome. Nephrotic syndrome means renal failure, CKD will cause pleural effusion, or hypoalbuminemia will cause pleural effusion, or if the patient has serositis will cause effusion. So serositis like in dengue, in sepsis, these patients will very commonly have pleural effusion. So wherever there is pneumonia, mostly there will be isolated unilateral effusion wherever there is pneumonia. So in this we can see what is pneumonia. Pneumonia is very well defined as it is a presence of a homogeneous patch. It is the presence of homogeneous patch on the background of a radiolucent lung parenchyma. Radiolucent lung parenchyma. So we know this blackishness, this radiolucency is all a normal lung parenchyma. So on this blackish or radiolucent finding, we have a homogeneous patch which is here in the right lower lung field. So it is a homogeneous patch in on the background of this normal looking radiolucent lung parenchyma. It is what is called pneumonia. So this is pneumonia. So there must be a pneumonia with a effusion because this angle is blocked. If the prominent effusion is there, usually we get a meniscus sign. What is meniscus sign? Meniscus sign is basically whenever there is prominent effusion and not consolidation. Usually in meniscus sign, they what you see is you see a meniscus where the basically the tip of that meniscus goes towards the costal margin. So this type of meniscus you will see, and here we very clearly can see the meniscus. So this is all meniscus. But in here, the meniscus is not that much prominent. So left-sided angle is completely clear, and right-sided there is a patch and the angle is blocked. So this is most likely pneumonia with infective. Most of the time, whenever it is infective effusion, it is always exudative effusion. Exudate means that will be full of the neutrophils or lymphocytes or the proteins. Whereas whenever it is transudative effusion, the neutrophils, lymphocytes will be lesser. Protein will be usually less than 1 gram. Whereas whenever it is exudate, the proteins will be very much high. It will be more than 1 gram. So so this was about infective pneumonia with effusion, which very well we can see in the upper X-ray. The second thing is congestive heart failure. Now, in for congestive heart failure, uh, what things usually whenever the patient has congestive heart failure, usually the patient have bilateral pleural effusion. So very commonly patient can have right-sided pleural effusion also if it is mild, but in congestive heart failure or pleural effusion, or fluid overload or renal failure, or hypoalbuminemia or cirrhosis. Usually, all these conditions they present with bilateral pleural effusion. But in CHF or congestive heart failure, usually the heart shadow appears very, very large. In CHF, usually the patient has cardiomegaly. Also, whenever we have renal failure because of the chronic lung disease, sorry, chronic kidney disease, those patients also very commonly have heart failure, chronic heart failure. So, in chronic heart failure or congestive heart failure or chronic renal failure or CKD, usually heart shadow will appear large. In this, we can very easily see the heart shadow is appearing so much large. So this is almost more than 50% of this line. So heart is appearing much large. So most probably this is congestive heart failure effusion, because in chronic heart failure or congestive heart failure we usually have bilateral pleural effusion. Here the bilateral effusion is there, heart is appearing large. So this is most probably congestive heart failure or CKD or acute renal failure where we get bilateral pleural effusion. In fluoro overload, definitely will get uh, uh, bilateral pleural effusion, and in fluid overload, patient will mostly have anasarca. Patient's hands will be swollen, forearm will be swollen, face will be swollen, bilateral lower limbs will be swollen in fluid overload. Whereas if it is congestive heart failure, most of the time only patient may not have any facial edema. Most of the time, if it is congestive heart failure, the edema will be most prominent first on legs, then abdomen, that is ascites, and then the face. Whereas for renal failure, most of the time facial edema is there, bilateral pleural edema is also there. In hypoalbuminemia, definitely patient will have bilateral pleural effusion, but in hypoalbuminemia, most of the time you will get pedal edema first, and pedal edema is very common in hypoalbuminemia patient. And most of the time, patient will have CLD or chronic renal failure, which is the reason why albumin loss will be there. And in serositis, like in dengue or in sepsis, most of the time, if it is only serositis which is causing pleural effusion, the effusion will be always very much mild. It is usually not in very much significant form. So in serositis, effusion will be there, but it is almost always mild only. If the patient worsens a lot, then only that serositis will cause a moderate to gross pleural effusion. But usually, only isolated serositis usually presents with only mild pleural effusion. So here it is very clear that there is a large patch, consolidation patch with pleural effusion, because this angle is blocked, whereas this angle is completely clean. So this goes in favor of infective, means pneumonia with effusion. Whereas here the patient has bilateral pleural effusion, there is apparent increased shadow of heart suggestive of cardiomegaly, which suggests congestive heart failure. Most of the time these patients have ischemic heart disease or chronic heart failure, or most of the time patient may also have chronic kidney disease presenting with infective exacerbation causing bilateral pleural effusion, or any other reason causing bilateral pleural effusion. um, for now, this is all for now, and thanks so much.